The association of non-index hospital with readmission rates for both acute myocardial infarction and congestive heart failure. This is of great interest nationally because there are associated financial penalties with excess readmission rates. So what we've determined by querying the national Medicare data files is that hospitals that have a higher proportion of patients readmitted to hospitals other than their hospital also have higher readmission rates, which is interesting and it's important for several reasons. First of all, the hospitals want to know this because they're getting financial penalties, but it may be that hospitals that are smaller or hospitals that have a greater proportion of patients admitted to other hospitals have structural disadvantages in terms of the penalties. It also may suggest that hospital consolidation may reduce readmission rates because perhaps one of the reasons why these hospitals that have more people admitted to other hospitals have higher overall rates is because there's not much coordination. Again, a fundamental problem in American medicine is coordination of care between different facilities. So if I'm a hospital with all of my patients after leaving my hospital goes to another hospital, the first hospital's readmission rates will be higher. So it suggests that a better integrated, better coordinated system may actually reduce readmission rates. It's well known that hospital consolidation causes prices to go up, but it's a little bit less clear whether quality goes up too. And it may be, from our findings, a suggestion that increased consolidation and larger hospital systems may lead to reduced readmission rates through better coordination of care. Some of these readmissions are totally unavoidable. You can have a heart attack and then a pneumonia 2 weeks later, and there's really nothing you can do about it. But there are other sorts of situations, and this is crucially important, where patients have chest discomfort that's maybe very low risk after a heart attack. You can imagine these are very vulnerable patients, a 50-year-old patient who's been well his whole life and then all of a sudden has this condition and then leaves the hospital, is scared to death, has young kids, may have a little bit of twinge of chest discomfort. To a cardiologist, it's not particularly concerning because there are features of it that aren't concerning. But it's hard to know for a patient, and it's hard to know. You can't necessarily get in with your doctor the same day, so they go back to the hospital. In the new hospital, they don't know the records from the old hospital, so then they get nervous and admit them to the hospital and do a lot of testing. So this kind of thing could be interrupted. It's wasteful because it wastes medical resources and costs. It's also unpleasant for the patients. Patients don't want chaotic readmissions to different types of hospitals. They want to be empowered. They want to be able to be in touch with their doctor. They want to be able to understand their disease process. With coronary artery disease, there's a difference between chest pain that happens with exertion, chest pain that happens with rest. There's some low-risk symptoms, pain in the right hand. There are all sorts of different types of symptoms that patients can experience. But for patients to be empowered about understanding their disease process, they need to understand the difference between the different types of symptoms. And I fear that in our healthcare system, we don't do enough of that. We're very, very good at opening arteries and heart attacks. We're extremely good at it. We're much, much less good at coordinating care, at making sure patients are educated and empowered. The truth is, it's much easier to book a reservation at a restaurant than it is to get in with your doctor. And a lot of it's call your doctor for a follow-up appointment. You call them, and then there's a voicemail, and no one calls you back, and you're scared, and that's how you end up in an emergency room. There are certainly cases where people need to go to the emergency room, and certainly cases where there are emergencies where they need to come in. But I think there's a lot of these cases that are manifestations of a healthcare system that's not well coordinated, not very patient-centered. You can see in other types of countries. In some countries in Europe, for example, readmission rates are much lower, in large part because compensation systems are different, and we don't pay huge amounts of money for procedures and relatively low amounts of money for seeing patients in the office, counseling, and so forth. Healthcare is a team effort. It's your doctor, it's your nurse, it's your medical assistant. The family should be engaged. The patient's a part of the team. We need to think as a team about how to empower patients to understand about their disease. The truth is that if one of our parents had a heart attack, we would be able to really make sure that they understood what the different types of chest pain might signify, and those patients would be much less vulnerable. We should hope that every patient feels like they can have enough empowerment that is the goal, that they know exactly what to look for, they're not scared, they know what to watch for, but they also understand symptoms that may not be as worrisome. We should also hope for a system where medical records are transferable between hospitals and that patients aren't readmitted to the hospital simply because Hospital 1 doesn't know the details of Hospital 2, the hospitalization at Hospital 2. I think it's extremely hard to do for an individual hospital. I think we need to be aspirational about the system. We need to change the system so that they're not spending as much time doing paperwork, so that they're not spending as much time doing all this other stuff during the day, so that they are able to spend that amount of time with the patients. The patients want it, the patients need it, it's the right thing to do. A lot of it has to do with distortions in the compensation system, that for doctors get paid a lot more for doing procedures than sitting and talking with patients. There's all sorts of regulatory barriers. You can't, if you talk to your patient electronically, you can't bill for it as if they came in the office. So for counseling for patients, if we're going to get paid for the visit, we have to bring them in physically to the office. But if you're just counseling about chest pain, couldn't it be done over the phone? Couldn't it be done over email? Couldn't it be done over teleconferencing? And why isn't it? The reason why it's not is because the compensation system, without justification, rewards in-person visits. And patients don't want it. Doctors don't want it. It leads to inefficiencies in the systems. And then we hear all the time, doctors are too busy to talk to me. They are and they aren't. They are because of all this other nonsense that doctors have to do. But if in an aspirational sense, you could imagine a system where counseling and empowering and getting people to prevent problems before they occur would be an intrinsic part of the practice of medicine. I think it probably was once true. That time was probably a long time ago, and I won't tell you what stage of my life I was at that point. It's not a time that I've known in my career, but I think it's something that we can hope for and something we should work for. There is a big debate right now, and it's been a furious debate in Massachusetts about what the proper size of a healthcare system is. So not so much hospitals buying other hospitals, but theoretically, if hospitals merge into large systems, when I, as a patient, end up at another hospital, the electronic medical record will be integrated, and as such, there'll be less chaotic transitions of care. Now, I know that there's also very legitimate concerns about prices, that as you consolidate, provider organizations may drive prices up. So that's something that needs to be balanced. We know much more from the economics literature about what happens when hospitals consolidate into systems in terms of prices. We know much less about quality, and that's what I'm trying to work on. We are conducting other analyses with the Medicare data files. We want to understand how hospitals can be best arranged to give care to patients that's well coordinated, that's timely, that patients want to receive. We're very eager to continue using these data files because we think that these national data files give us an opportunity to understand many of these trends nationally and hopefully generate actionable findings that can deliver a better healthcare system. Healthcare in America is becoming more disorganized, more disjointed, and more expensive. And it's just a trend that's unsustainable, and we need to start chipping away at that and moving back to a system that the American people can be proud of.